ADLs, probably the most missed section and one of the most impactful on reimbursement and outcomes that there is. So let's look at the ADL and IADL conventions, the rules. ADL questions assess the patient's ability, not necessarily their actual performance. This is very important to remember. Willingness and compliance are not the focus of these items. Items address the patient's ability to safely, you see that is bolded and underlined, safely perform the ADLs. So we need to look at their current physical status, their mental, emotional, and cognitive status, and their activities permitted, and their environment. The ability can be temporarily or it can be permanently limited by physical impairments such as range of motion or poor balance. Emotional, cognitive, behavioral impairments, they may have dementia, memory loss, even fear of going out or fear of doing something, maybe they fell in the tub and now they fear getting in the tub. Sensory impairments, such as impaired vision or pain, and environmental barriers, stairs, narrow doorways, and the location of their bathroom or their laundry. As a patient is on with us, or as a patient has maybe an illness, their ability may vary. It may go down, and as they get better, their ability goes back up. That's what we want. We want, as we're seeing the patient, for their ability to get better. If the patient has medical restrictions, once those are lifted, then the patient's ability then increases. We had a lady at church that fell and fractured her arm. So, but as she came out of the sling and all that, her ability to do things got better. Or maybe we've modified their environment. Maybe we've ordered grab bars for their bathtub, and now their ability to get in and out of the tub is different. The clinician must consider what the patient is able to do on the day of the assessment. And the day of assessment is while you're sitting there in the previous 24 hours. If that ability varies over time, you're going to choose the response describing the patient's ability more than 50% of the time period under consideration. While the presence or absence of a caregiver may impact the actual performance of activities, it does not impact the patient's ability to perform that task. The patient is, and here's an example, the patient is able to put her clothes on once they're laid out on the bed, but then the caregiver is hospitalized. Is the patient able to then get her clothes out? No, she's used to somebody putting them on the bed. So the patient's ability didn't change. So a lot of times you'll see these questions and a clinician will put zeros down that the patient's functionally independent because they live alone. That does not change the patient's ability to safely perform those activities. It just means that that's their only choice. If the patient's ability varies between the different tasks, including a multitask item, report what is true in a majority of the included tasks, giving more weight to tasks that are more frequently performed. The scales present the most independent level first, or zeros, meaning that they're the 20-year-old walking around. Then proceeds to the most dependent. Read each response carefully to determine which one best describes what the patient is able to do. Definition of bedfast. Chapter 3 of the OASIS manual defines bedfast. Bedfast is not what we think. Bedfast refers to being confined to the bed either per physician restrictions, physician has ordered it, or due to the patient's inability to tolerate being out of bed. That means Even if you have to get them up with a Hoyer lift, if they sit in a chair, they are not considered bedfast in the OASIS guidance. So if they can tolerate being out of the bed, they are not bedfast unless they are medically restricted to the bed. There is no time frame for them to be out of bed. Just if they can get out of the bed, they are not considered bedfast. So that's going to be important as we go through these items. The assessing clinician will have to use his or her judgment when determining whether or not the patient can tolerate being out of the bed. So if a patient has severe orthostatic hypotension and they're in the bed and you try to sit them up and then they just vomit, they cannot tolerate being out of bed and they would be considered bedfast. For example, a severely deconditioned patient may only be able to sit in the chair for a few minutes, is not considered bedfast, and he or she is able to be out of the bed. A patient with multiple system atrophy becomes severely hypotensive within a minute of moving from the supine to the sitting position and is considered bedfast due to the neurological condition. So what is the difference between willingness and compliance, which do not have impact on the OASIS scoring, and cognitive, mental, emotional, behavioral impairment, which may impact the scoring? The answer is if a person is unwilling to bathe appropriately, no, this is another question. If a person is unwilling to bathe appropriately, resulting in poor hygiene and offensive odor and increased risk for infection, isn't the patient suffering from some sort of cognitive, mental, behavioral, or emotional problem that would cause this unwillingness and noncompliance? And it seems that this unwillingness is a symptom of a deeper psychological problem. Or a patient may demonstrate that they can safely ambulate while using a walker, but then as a matter of choice decides to walk without it. Another patient may demonstrate that they can safely ambulate while using a walker, but then consistently walk without it, forgetting that they have a walker. So that happens too. Or they get the walker and they lift it up while they walk. For the purposes of OASIS scoring, nonconformity or noncompliance should not automatically be considered indicative of a deeper psychological impairment. Now, I lean more toward if they've been instructed and you just kind of have to guess. Because if they've been instructed and they're one of those stubborn men, probably, then you know it's probably noncompliance. But if it's a sweet little lady and she just keeps doing it, not that I'm saying it's between a man and a woman. I'm not saying, maybe it's a sweet little man, and he just keeps forgetting, then that is a whole different thing than noncompliance. A lot of times we get our dementia patients saying they're noncompliant when they're really not noncompliant.
I can't remember that time.
Right. So we have to make the decision, or the clinician is supposed to make that decision if the patient is noncompliant or if they don't have the mental capacity to remember to do things. The response related to assistance of another person includes those patients actively participating in performing a task, but needing assistance of one or more persons to safely complete that task. Service animals counts as a device and not as assistance. So remember, assistance can be a verbal cue. I'm just telling you to do something. It can be just watching you, or it can be something hands-on. Accessing the location and or implements. When should a patient's ability to access the location and or implements needed to complete ADL, IADL tasks be considered when scoring the OASIS items M1830, M1845, M1870, 1880, and 1890? The OASIS ADL, IADL items consider the patient's ability to access the needed items and or locations where the task is performed unless item guidance specifically excludes these from consideration. And there are 5 IADL items where these are excluded. The first one is M1830, which is bathing. Focuses on the patient's ability to access the tub and shower, transfer in and out, and bathe the entire body once the needed items are in reach. The ability to access the bathing supplies and prepare the water in the tub or shower are excluded from consideration when assessing the patient's bathing ability. So if somebody sets all that up, what is their ability to do it once it's set up? Exclusion for M1845 focuses on the patient's ability to access needed supplies and implements and manage hygiene and clothing once at the location where toileting occurs. The ability to access the toilet or bedside commode, transfer on and off the bedpan, and to use the urinal are excluded from consideration when answering the patient's toileting ability. And exclusion for M1870 focuses on the patient's ability to eat, chew, and swallow once the meal is placed in front of the patient and needed items are within reach. The ability to access the location where the meal is prepared and consumed and transported